Terson syndrome. Terson syndrome is a well-described disease. The aim of this video is to present some possible pathways by which the blood may enter into the eye and the implication of this on the clinical picture and functional results. In the first case, after vitrectomy, we observe attachment to the vitreous on the optic disc. We suggest that this is the entry site for the blood. A similar clinical picture was also noted in the other eye of this patient. Clinically, along the vascular arcades we observed brownish spots which may correspond to blood remnants. Postoperative HRT examination of the optic disc shows an elevation in the center, which corresponds with the entry site. In the course of postoperative follow-up, we see normalization of the contour of the optic disc and the macula. An identical clinical picture was diagnosed after vitrectomy in the other eye of this patient. In both eyes, 20/20 visual acuity was achieved. We made similar observations in our second case. Spectral OCT sections in different meridians demonstrate that the entry site for blood was probably not only in the center of the disc, but additionally blood spread along the retinal vessels and produced localized ILM detachment. The contour of the macula is completely healthy, and none of our observations had any influence on the final results, where 20/20 visual acuity was recorded in both operated eyes. Localized ILM detachment is better visualized with 3D spectral OCT. In this next case, bilateral Terson syndrome is again present. After vitrectomy, we see complete ILM detachment over the macula. A postoperative HRT picture suggests that blood entered the eye along the upper vascular arcade and detached ILM centrally. We suggest that following this, blood appeared through imbibition into the vitreous cavity. If we look at the clinical appearance during vitrectomy, we see a blood clot connected to a pacified and detached ILM. We observe intense bleeding from the upper vascular arcade when ILM is removed. This observation additionally confirms that the observed structure is ILM. Postoperative HRT and spectral OCT confirms our observations by presenting the pictures of the optic nerve head and upper vascular arcades and macula. Additionally, spectral OCT scans present edema of the macula without any epiretinal membranes, both in single and three-dimensional scans. Despite observed pathology in both eyes, 20/20 visual acuity was recorded 6 months postoperatively. Our final patient here was presented for treatment after resolution of blood from the vitreous following severe head trauma. Epiretinal membrane as a remnant of blood coming from the optic disc into preretinal space was diagnosed. During vitrectomy, epiretinal membrane was partially cut away. After trypan blue staining and ILM removal, it was noted that the membrane spreads under the fovea. These observations suggest another entry site for blood, which is probably both sub- and epiretinal. In this patient, 1 out of 50 visual acuity was achieved. In conclusion, we would like to state that 1. The entry site for blood in Terson syndrome is usually around the vessels coming into the eye, but inside the eye, blood may spread directly into vitreous, sub-ILM and subretinal. 2. Presented pathologies have a direct influence on postoperative anatomic and functional results.